you know how it takes a village to raise a child? It takes a village for someone to be in the twilight years towards their last years of their life to have a dignified death. So that takes a village as well, CN. And I think the times come where we need to empower patients, people really, to form their own compassionate community early on.
Hi, I'm Cian Xiao.
And I'm Sammy Winemaker. We talk about ways to put the human back at the center of care.
The Waiting Room Revolution starts right now. All right, welcome back to the Waiting Room Revolution. Today we have Dr. Ashwin Kaniah, who is from Australia. He has been working as a general practitioner or a family doctor with a special interest in geriatrics and palliative medicine. And he just completed his palliative medicine advanced training. And so he's going to be a palliative care consultant at a hospital in Brisbane, Australia. Ashwin, welcome to the podcast.
Hi, CN. Thank you very much. I'm very, very happy to be here today.
Well, I'm excited because we sometimes have clinicians like doctors on the show, but we haven't had one in a while. And you're a family doctor who now has gotten extra training in palliative care. So maybe we could start there. Like, what drew you to, in your family medicine practice to have an interest in geriatrics and palliative medicine?
Yeah, that's a really good question, CN. So just a little bit of a preamble before I got into general practice training. I initially was a medical registrar and physician's training. I initially had a passion for wanting to specialize, dual train in palliative care and geriatric medicine. And life got in the way, and I just somehow ended up in general practice training instead, which I think was a much better fit for me because I really am a case manager at the core. I really like managing people as a whole and not just looking at their medical issues, but their biopsychosocial issues and how to give them overall a good bird's eye lens into their care. So left Sydney and moved up to Newcastle in 2018 to enter general practice training. Finished that, and upon working as a GP specialist in Newcastle, I found myself doing lots of aged care assessments, diagnosing mild cognitive impairment in my own practice. I kind of had carved a niche for myself as a GP with a special interest in geriatrics and palliative. Hence, I was getting lots of direct referrals from my own colleagues in the same practice for geriatric syndrome issues and cognitive impairment. I was doing nursing home work as well as a GP trainee. And just over the 2 years on finishing GP training, CN, I just found myself doing the work already as a GP. And coming from a physician's training background, I just realized, well, it was a calling, I suppose, for want of a better term, just to specialize in palliative care with the hopeful intention in the future of forming a bridge um, in terms of geriatrics and dementia care assessment in a timely manner to involve palliative care, because this is a big gap I see that by the time palliative care is referred in dementia cases, for example, um, patients are at the very advanced stage of their dementia um, prognosis, as you know. And there's lots of suffering and emotional burden, not just from the patient, but the family and their carers. And I just feel that by the time we get called to the party in palliative care, I feel that we're just doing more of a band-aid approach, and it would be really helpful for us to be involved at a much more earlier stage, especially when it comes to advanced care planning discussions and what's of meaning and value to that patient at that point in time to help their carers and substitute decision makers help make informed decisions for their loved ones when they actually enter the advanced stage of dementia and lose capacity themselves. So that was the main inertia to push me into palliative care training. And 3.5 years down the line, I've learned so much, so much. And I think what I can say, sure for sure, is I'm really happy that I chose to go into palliative care training, CN, because I think with my personality and my psychology and my outlook in life, I think it's where my skill set best sits, if that makes any sense.
For sure. Yeah.
Many people have asked me whether I will ever continue doing general practice work. That's a very good question. I would love to continue it in some form or another, but I think for now I'm just going to focus on being um, palliative care specialist.
And you have really unique insight because that I think because you've been on both sides in a way as done the training as a specialist, which is perhaps like you said, people get brought in near the very end, the 11th hour, but also the early upstream um, conversations and gaps. So can maybe my question is really about now that what would you say to your GP colleagues
Mhm.
about the things that they could do that are early palliative care approaches, even if they don't want to label it that, but the things that you're
Mm.
doing or that specialists, palliative care specialists are doing that actually they could just as easily do.
Yeah, that's a really good question as well. And I think, the first thing that comes to mind, CN, is taking the time for advanced care planning discussions, which basically ties in, with what your and Sammy's book is about, hope for the best, plan for the rest. Um, I think, look, GPs do advanced care planning well in their own right. How, having worked as a GP myself and knowing how my own colleagues operate, I will say that it's very variable, and that general practice is becoming more and more under the pump and time poor. And I think the reality is that not just in Australia, but across the world, general practitioners and family medicine physicians are looking after a higher burden of chronic and complex patients. Um, Gone are the days, well, back when I was in medical school and did my GP attachment, gone are the days of the 10-minute consult of coming in just for your scripts and okay, you're off on your merry way, out the door. When I was a general practice registrar, at least half of my patients, were in their 40s and 50s with multiple chronic and complex comorbidities. And that's even not taking the mental health burden on top of things. So I think what the difficulty in being aware to screen for cognitive impairment or geriatric syndrome issues, or the burden of chronic incurable illnesses. I just think GPs have a lot to do. They are doing the best they can, but yeah, I think that that's just where things are at right now.
Do you think that some of the skills that maybe you feel that like the communication skills, for example, and like how you bridge into some of these conversations. Do you feel like that is something? I'm sure you got extra training or a lot of experience with that in your palliative care training, but that perhaps, that's sort of the bread and butter of family medicine as well. And that if they had more time or if they had the intention or maybe the confidence, they could maybe help to have some of these bridging conversations as well, which is some of this is what we are managing today, but these are some of the things that we might need to think about in the future.
Yeah.
And, my role as a GP could be to do that. I mean, I wonder how, especially in Australia, if you see that GPs that as part of their role, or they're really uh, too pressured and have to, and sort of relinquish that to palliative care specialists.
In terms of having advanced care planning discussions, you
I
mean?
mean, you're calling them advanced care planning discussions. I mean, I'm thinking more broadly, like
All
the
goals of
idea
care.
of just helping people navigate this long journey,
Yeah.
say, of dementia,
Oh, I
or
see what you mean. Yeah.
yeah.
Oh, look, I think even when I was training as GP, we are taught to have to support patients in navigating diagnoses and having meaningful discussions with them about what their core values are and what they would want, not just at the end of life, but at various points of their journey. But the problem is, I think GPs have so much else to do at the same time that I think the way consults are set up as well, CN, is, not to go into the financial side of things, the financial remuneration of item numbers that GPs can bill for, also factors into the amount of time they can spend with each patient to, let alone doing a comprehensive clinical assessment, typing up referral letters, or organizing referrals or investigations, yeah, and then moving on to the next patient in a timely manner. I think as a GP, when I look back, I definitely knew had I continued as a GP, and I did joke with many of my colleagues about this, I would never be a rich GP because, you know, some GPs would manage to churn out 40, 50 patients in a day. And that's leaving aside doing, skin cancer procedures or women's health procedures, sexual health appointments. Um, so I think GPs are really are trying their best. I think more work would need to be done in terms of collaboration, I think, between the College of General Practitioners and the College of Physicians, specifically geriatricians and palliative care physicians, to come up with more guided templates for GPs to potentially use to help patients navigate these discussions um, before even referring them to palliative care or before referring, for example, if it's a dementia case, referring them to a geriatrician to confirm the diagnosis, but just how to have these navigation discussions. I think more broadly speaking, and you and Sammy probably are aware about this, these these tokens stem back from medical school training itself. That whilst we're taught in medical, well, when I was in medical school, we're taught how to treat, but we're not really taught about how to talk about the unknown.
Hmm.
And that's a huge chunk of what general practice actually does. We deal with the unknown as family medicine physicians all the time, because the moment the patient walks out the door, you're not really entirely sure if they're ever going to come back to you. So you try to deal with the most pertinent issues at that point in time. But when it comes to dealing with the unknown and navigating the gray of a chronic and complex illness, I think those discussions, especially your and Sammy's book, would really be vital for medical students to even have at a medical school level.
Yeah. Do you think there's a if patients and families came um sort of armed with, their like with the knowledge, I guess with uh the um you know, i- sort of like they already know the questions they've asked and they sort of
Mhm.
declare themselves as someone who wants information,
Yeah,
understands their illness, or this is what I understand about my illness, da, 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 and this is my team, and nurse GP, like this is what I need from you, or these are the questions I have, like let's get to it. If I wonder if I mean that's kind of our vision is that, and we have a
that
workbook
would
that
be in an
that
ideal
activates
world,
people.
Cian.
Pardon?
That would be in the perfect ideal world.
Yeah, well, that's what we're trying to do with the book.
Yeah,
We have a workbook out, but we can get into that in a bit. But building on what you were just saying, I wanted to just follow up because you talked about engaging family physicians and the college, but I know you're also a big supporter of compassionate communities,
very
and
much so.
which is broader, all interprofessional healthcare specialties, not just doctors, but nurses, social workers, home care workers, et cetera, but also the broader community. And so I'm actually curious, like how you got connected, or how, what made you kind of realize or get attracted to community as a part of the key to, better dying and death.
Oh, wow. I really love this topic. So thanks for bringing this up. So when I was even working as a GP registrar, it became glaringly obvious to me about the chasms of deficits between the hospital system and primary care. And whilst general practice, primary care physicians, nurses, OTs, physios, allied health members, we're doing the best that we can at that point in time. There's still a huge gap into how care translates when patients leave the hospital to follow up with primary care in the community. And there's an even bigger chasm. To my knowledge, case managers don't actually exist in the community scene. Um, when I was a GP, I could refer patients of a certain socioeconomic demographic, or if they met certain criteria, such as if they were Aboriginal Torres Strait Islander patients, to publicly funded case managers who will pick up the phone and them to just make sure that they're aware about all of their medical appointments, allied health appointments, and case manage their discussions with nurses in the community. So when I realized that And the other point as well is aged care in Australia is in a huge deficit in terms of having community aged care providers to
Mm,
maintain autonomy and quality of life at home. So we're always going to be operating from a place of deficit of not having enough services to maintain a vulnerable older patient at home, even once they've had a my age care assessment. That's a whole separate discussion in terms of the nomenclature, the finances behind all of that, and I'm
sure.
not going to get into that. But the short end of the stick is, I think I realized that using the same format would not work. And when I came across Compassionate Communities Australia, it was like a light bulb moment realizing, oh my God, this is basically what um, third world developing countries actually naturally do. You know, growing up in Asia, when I've listened to talks about palliative care physicians in Africa, for example, where they hardly have doctors and nurses to provide care in the community steps in as a tribe. You need a village. And someone once told me, a friend or colleague did say that you know how it takes a village to raise a child? It takes a village for someone to be in their twilight years towards their last years of their life to have a dignified death. So that takes a village as well, CN. And I think the times come where we need to empower patients, people really, to form their own compassionate community early on. One of the things that stuck with me from the 2023 Oceanic Conference, one of the plenary discussions was one of the keynote speakers mentioned, if you don't have any friends, start making some now because you're going to need them in your twilight years of your life. Well, that's not the only reason, of course, but that really stuck with me that, who are my inner core and outer core people in my life, and who could I actually rely on, for example, if I was not able to do my groceries, or if I was not able to take the dogs for a walk, or take kids to an appointment, for an example. Who could I rely on for things like that if I didn't have services? So yeah, that's one of the core cruxes working in primary care that made it glaringly obvious to me.
Um, we're talking about all the healthcare uh, stuff, but you've also are a researcher and you won Best Trainee Research Project award, right, in palliative medicine, I think this past year. So could you tell us a little bit about that research project or what your research
Oh,
interests are about?
thanks, Ian. Yes, very, very humbled and honored to be the recipient of that award. Was a very welcome surprise, rest assured. So, again, one of my other passion projects, in life in general, is to provide more inclusive care for the LGBTQI plus community, in general practice and palliative care as well. And so when I was deciding on a topic for my research project, I, got together with my research supervisor, proposed my question. We did a brief literature review and found very, very limited studies. We know there are lots of systematic reviews and original papers analyzing the lived experience of LGBTQI patients in cancer and palliative care, but there are very limited studies out there looking at behaviors and experiences of healthcare practitioners practicing inclusive palliative care, what their lived experience is, and perceived barriers. So that's what informed the deficit of these robust studies informed the question to do a systematic review. It was a mixed method systematic review, and from the four databases we looked at, only 11 papers met our inclusion criteria, and that itself speaks for itself. And most of those papers were qualitative studies in themselves. And I think from those 11 papers, I then came up with a narrative thematic analysis, which took up a year of my life, blood, sweat, and tears, coming up with verbatim quotes to actually be subcategorized on a narrative thematic basis. And the crux of the 4 or 5 narrative themes they came up with, one of the glaringly obvious things was that healthcare workers, doctors and nurses working in palliative care, have a resounding need, self-proclaimed need for more knowledge and training. But the converse of that was um, the unknowns of not knowing what you don't know. And
Mm,
that was very clear in terms of not knowing what education and training to ask for and not having enough cultural sensitivity training. That was number
hmm.
one. Number two, it was quite interesting. Lots of the feedback from doctors and nurses was that they were not aware about having an appropriate repository of information. So lots of electronic medical records and paper medical records, patient screening information tools don't actually have an appropriate SOGI section, and SOGI stands for sexual orientation and gender identity, which is the currently worldwide accepted nomenclature for sexual and gender minority patients. So there's no actual generic SOGI information repository on hospital and primary care repositories, and that in itself is a glaring lack of a prompt for people to ask these questions when talking to patients. Yeah.
So you so was a part of your research also to develop e-learning modules that would train clinicians to I think it was co-designed, right, with members of the LGBT community and as a way to sort of yeah, teach clinicians how to be more inclusive in their care.
Yeah.
Was that a spin-off from that or was that connected or in
So that
parallel?
actually was before my actual research project. So even when my first year of advanced training, I did work with LGBTQI Health Australia, which is another federal government funded organization. And I was invited to actually come on board as part of a co-design committee to actually formulate an e-health learning module. So it's broken up into four modules for healthcare workers in palliative care to actually have not just advanced care planning, but palliative care discussions with patients with unique needs in this subset population. So that was launched about 3 years ago, officially. And I was part of the initial grassroots discussions, to formulate these modules. I wasn't there for the end of the launch in itself because I was really embroiled full-time in palliative care training, but I'm really grateful to have been part of it. And I do use, my own voice as an advocate in all the healthcare organizations I've worked in as a PAL care trainee to make people aware about these e-health learning modules, which have been approved for continual and professional CPD points from the primary care perspective by the Royal College of General Practitioners. Um, so I think again, it's a good point you've raised that there's a lack of awareness about the information training tools we have out there.
Hmm.
Even on a health education training platform, we call this HETI, for example, in New South Wales, you have plenty of mandatory training modules, for OH&S safety, Aboriginal and Torres Strait Islander cultural sensitivity training. There are actual LGBTQI rainbow health learning modules on these local health district platforms, and I did them myself, and I have to be honest, and they're really pretty good. They kind of mirror the e-health learning modules, which we designed with the co-design team. But the important thing is people aren't aware about these training modules, Ian. So whenever I give talks about inclusive care or talks about my research paper, for example, I do make it a point to spread the word. But I think there just needs to be more awareness about training modules, about training resources out there for doctors and nurses.
Can they be taken by people from outside of Australia, or it's really geared for people in New South Wales? Or
Oh, it's a good question. I wouldn't, well, with the platforms on Hetty, for example, you would need to be New South Wales Health employee to have access to that platform. But there are other inclusive training modules that have been formulated for example, with the LGBTQI Health Australia. I do believe, and don't quote me on this, I'll have to look up on this. I do believe you are able to subscribe for it, irrespective of your location. I do believe so.
Okay, so I have a question here. I think you said that this training was designed for people, for providers who are specializing in palliative care. But do you think that the education, the techniques, the frameworks, could they be applied for people outside of palliative care?
Oh, totally. So it's same but different. It's so and this is what I love about these modules, because the first two modules actually talk about the lived history and trauma of the LGBTQI community, people who have lived through the 1980s AIDS pandemic. And when you're dealing with elderly patients, for example, from that background, living with the trauma, it's a different mindset compared to the current younger generation of the LGBTQI population, whose lived experience is entirely different. So just being aware about the nuances about intergenerational experiences of
Hmm.
people living in this zeitgeist is super important for anyone working in the healthcare industry. Whether you're in primary care or working in the hospital system, whether you're a doctor, nurse, OT, physio, or social workers. I think social workers in themselves innately, have, are very inclusive by nature. But when I did give this talk at the previous grand rounds for the research paper I was talking about, had glaringly positive feedback from social workers saying that we would love for these training modules or for more training on inclusive care to be available on healthcare platform repositories. So yes, I think even stemming back from earlier at a medical school level, I think inclusive LGBTQI care, would potentially be beneficial as a topic discussion to plant that seed in students' minds, in medical students' minds, about being aware. I think one of the thematic theme reviews from my paper was generalization, homogenizing frame, looking at patients from a homogenizing frame. And there was some feedback from some healthcare workers, and this is stuck glaringly in my mind, Cian, that, oh, I've looked after one or two LGBTQI or queer patients, and therefore I know how to look after all LGBTQI or queer patients. And therein lies a difference between equality and justice,
Mm.
because some practitioners have an egalitarian frame in terms of I treat everybody the same, and it's a huge danger in that, in missing out the unique needs of the individual person walking into the room to talk to you. And if you're starting on that platform, you're very unlikely going to get there on your own volition.
Yeah.
Lots of healthcare workers did feedback that they relied on passive disclosure of either patients or patients' relatives disclosing themselves, or passively from other colleagues, as in, if the social worker or OT or physio got that information, pass it on to doctors. So I think a lot of work needs to be done at a grassroots earlier level to have a cultural change. And I think one of the biggest points, CN, is cultural change, as you know, takes time. It's going to take generations for this to change, so it has to happen at some point.
Yeah. I mean, I want to pull on the thread because you kind of touched on it a little bit, which was the what are the challenges that LGBTQI plus people face? And you talked a little bit about the mistrust or the distrust, but what is the sort of the kinds of things that they might experience, particularly when they're, facing a serious illness or, facing down end of life? Like, what are things that might be unique where this intersects with gender identity that I think perhaps people may not appreciate?
Yeah. So, I mean, from my literature review on lived experiences of patients and their chosen family themselves, just separate from my paper, I am, aware of, feedback surveys, within the palliative care setting. One of the biggest concerns is of why many patients themselves remain in the closet, so to speak, as they're afraid about their access to care being limited, that they may
Mm,
not get the same treatment if they were to disclose their status, number one. And leave palliative care out of the question. I think when you're looking at the vulnerable and older age community, one of the biggest concerns I have had personal feedback from my time in general practice from older patients from the community is that will I be treated with the same dignity if I were to go into a nursing home that does not accept or respect, who I am as a person?
mm,
So those are common themes of threads of fears of not getting equitable access to treatment due to the internal bias of healthcare workers who are in charge of their care and in their twilight years entering residential aged care facilities. Um, those are the main common threads. The transgender community, I have to, do a mention about the transgender community, and that one of the common themes and feedback from surveys in this community is not just in a palliative care setting, but in a nursing home setting as well. In that, would my hormone reaffirming therapy actually be continued if I were to enter a nursing home or if I were to enter hospice and palliative care? And these are all really important points, Ian, because as palliative care physicians, we're not, we don't have mandatory training on hormone reaffirming therapy. These medications are often started by prescribers in primary care. I was a hormone reaffirming therapy prescriber myself when I was a GP. Um, and I think there's lots of assumptions on patients to have that already, to be on a plan with the ongoing prescriber, you know. But I think in terms of dealing with the questions of sensitive questions about when would one want to entertain ceasing hormone reaffirming therapy at the end of life, and like so with HIV patients on antiretroviral therapy, there's a huge gray area discussions about the cessation of antiretroviral therapy in a palliative care setting at the end of life. And I think there's lots of training which needs to be done to guide healthcare workers to have these discussions.
hmm So maybe putting you on the spot a bit, but what are some practical tips, advice you might give healthcare providers, your colleagues,
Mm,
on how they can make people feel more respected and understood? I guess particularly LGBTQI plus people, that we can be more inclusive. Like, what are some of the best tips that they can take away and say, this is stuff you should be doing right away?
yeah. Um, so I'm really taken back to Prof. Noel Javier, who's an American palliative care and geriatrician who's done lots of work in inclusive LGBTQI talks and education. I came across her work on YouTube actually, and that's the benefit of YouTube. And this stuck with me. She actually raised this a one key dignity question, which I use in my daily practice as well, in terms of when you're seeing a patient, rather than asking, specific questions about, who's your partner, who's your wife, or, what's of value to you in your life, to have an open-ended question at one point of your assessment to go, could you tell me one key aspect of yourself or one key thing about yourself that would help me look after you better? That's the one
Mm-hmm.
key dignity question. And from that, I stem on to and talking about people of significance in your life rather than using um, homogenizing language such as husbands, wives, or partners. Ask someone, do you have anyone of special value in your life? Yeah.
Love that.
So,
Yeah.
yes. So
Yeah,
that's
and I think
one
you were
key thing.
referencing the patient dignity question, the PDQ, which was Harvey Chachanov's, right? Yeah, what do I need to know about
Yes,
you to
Chachanov's,
provide the best care
exactly.
possible? Yeah. But I
Exactly.
love your of who is important to you, who are the people that are important alongside. We call it the inner crew for exactly the same reason, to try to
Yeah. Yeah.
break out of
And
this idea of family, or, quote unquote
yeah.
family. Yeah.
Yeah. And Sian, in that same token, I have to say that one of the feedback that patients have given as well is each time a patient comes in to see you in clinic, right? It's a trust assessment. They are trying to suss out, can I trust this person who's talking to me?
Mm-hmm.
And they may not choose to disclose their status to you at the end of that consultation, but if you made them feel safe and inclusive with your approach, they will be thinking about it when they go home. And when they come back to see you or another colleague of yours or nurse practitioner or allied health member within the same organization, they may choose to disclose their status then.
Mm-hmm. Mm-hmm.
So I think that's another key point to pass on to my colleagues, and that what you do whenever each time you have an encounter has a ripple effect.
Yeah, you're building on a relationship in many ways. Yeah.
Totally.
Um, I wanted to pick up on another piece because we've been talking a lot about LGBTQI plus
Yeah.
and the education modules, but from your perspective, and you've looked on it from both sides, your research, your experience, do you feel like some of these principles uh, are not specific about to gender identity, but could apply to race, culture, um, and various other aspects, income,
Yes.
etc.
Yeah.
That, in a way, like I wonder if we could, it's like universal equity training or inclusivity training or safety training in a way, trust training,
Yeah.
that while it's important to have, understanding for each of these marginalized populations, many people come together with many different identities and, and uh, maybe have different values placed on those identities. So I wonder if there is a world where some of this education overlaps, and not that it's more we're making it too complicated, but could we simplify it so it could be picked up and used faster by having
Yeah.
universal principles? I guess I wondered
Yeah.
that.
Yeah, it's a really interesting question. You know, I'll be honest, I don't have an offhand, straight off the bat answer to that, but I have often wondered, where does the responsibility for this zeitgeist actually lie? I think from a healthcare practitioner perspective, when I give my talks on doing SOGI assessments, I very often allude to um, talking about this when taking a social history from a patient. And social histories of everybody's responsibility, Sian, they're doctors, nurses, physios, OTs, and you might get that part of the puzzle of the social history on your encounter and put that on the information repository so that the next person can have access to that when they see the patient. So, for example, when it comes to SOGI assessments in general, I always advise people, my colleagues, to use it in a normalizing tone, um, normalizing language, neutralizing language. Sorry, not normalizing, neutralizing language. That in the same token, when you're talking about smoking, alcohol, and taking a sexual history, talk about your SOGI assessments there. But from a broader perspective, all of this talks about individualized approach to care. And inclusive LGBTQI care, from my personal observation, parallels the same tokens used in inclusive Aboriginal Torres Strait Islander care in terms of individualizing what's important for that person, that population in front of you. So we know we have mandatory cultural sensitivity training, an important point I'd like to raise is I think we should stop using the term cultural competency, which is still used in lots of healthcare organizations, because Kerry Kandrian and Noel have raised this point beautifully themselves, in that the term cultural competency alludes to a very false sense of achievability. And once you've achieved it, I don't need to grow and learn anymore. Whereas cultural sensitivity is an ongoing spiral. It's an emotional and mental growth of a person as an individual. And I think if you start from a cultural sensitivity, ongoing learning perspective, that's where you're innately going to practice inclusive care irrespective of where you lie in the healthcare system, and not just from a sexual health perspective or an Aboriginal Torres Strait Islander perspective or LGBTQI perspective. You're going to be looking at the person who's in front of you where they come from in life, who are the people of value to them, and what's important to that person at that point in time. Does that make sense?
Absolutely. And I love that you talked about it's really about, personalizing care. And that is the perfect segue to how we met and why, I wanted to talk to you on this podcast was because
Yep.
we met at this presentation where in Australia and Sydney, where I was talking about the seven keys, and you came up to me right after saying that you thought this would be relevant for medical education, particularly for GPs.
Yep.
Who may not have a specialty in palliative care, but are doing that kind of work in a general way, as we talked about. What were you thinking when or what do you see as the potential for this spreading? Because we have always envisioned the seven keys as being for the public
Yeah.
and being patient led, as the revolution is from patients and caregivers coming to the system activated with better with more information or knowing how to get that information. But I think you were coming at it from this could be top down in a way, or the other direction, which is providers can also bring this in. So why were you so excited, I guess, after about some of the things
I
that we were
think,
presenting?
look, uh, when I first came across your book and your worksheets, your templates, the first question I asked myself is, oh God, I wish I had this when I was a GP to give out to my patients. Um, and I was going to ask as well, Cian, have you and Sammy in Canada approached family medicine physicians about the book and the worksheets in general with the seven steps? And do family physicians in Canada use it?
Yeah, so it's definite. So family, it just like I think in Australia, palliative medicine is a division within family medicine. So people who have a palliative care specialty first train as family medicine clinicians, and then
Right.
the palliative medicine specialty is like a fellowship, an additional 2-year fellowship. And so there are people. We have really great colleagues at our university who mostly do family medicine. So they have a family practice with, babies and moms and families and, for everyone in a community, but they have a special interest in palliative medicine. And so they might have a palliative care clinic or, have that extra skill set. So because of that, and we've interviewed some of these folks on our podcast, like we have a pretty good sense of how this might translate into primary care. And actually, a lot of my research is in operationalizing, and it's not my favorite word, but a good palliative approaches into primary care. And now it has spread into, interprofessional, all healthcare providers, really. But, the heart of it is primary care. And so actually, yeah, a lot of our work is working on educating healthcare providers because there's special envelopes of money for that. But we have been doing that for a long time. And what we find is, in a way, it's sort of the early adopters are the people who, preaching to the choir in a way. Like they already know and they're
Yeah.
doing it and we can learn from them, but we're still missing the people who don't know what they don't know. And you talked about
Yeah,
the unknown
exactly.
unknowns, right? So I
Yeah.
think it's still a challenge to get the cardiologists, the nephrologists, even the oncologists to
Yeah.
appreciate that an early palliative care approach is everybody's responsibility. And so
Yeah.
we continue to believe that it's a two-pronged approach and that patients and families are usually, at least in our cancer center, and we work in a city called Hamilton, um, and Sammy and I both live near there, and so a lot of patients buy the book and give it to their oncologist and say, "Read this, and I want to talk about
Yeah.
this, and I want to go
Yeah.
through these steps, and I want us to walk two roads," and so they're leading the way, and I see that as much more powerful as an opportunity to change clinician behavior, I think, than
Yeah.
say it's a mandate from the Royal College and within the next 3 years you must do this training, right? So
Yeah.
so we I think we have also been asked about medical education, like how do we get, this into the curriculum? And that, as you know, is very difficult because each medical
Yep.
school is its own entity and its own board, really, governing board. So I've been thinking about ways to do that, but I think first we have always focused on is the content right? Does it resonate? Is it useful? And then if there's an audience for it, they will find a way it will naturally spread. And I think that's what we've been seeing.
Yeah. I think, from my personal practice, had I had access to your worksheets, I would personally have been the moment I, take over care of a patient with a chronic incurable illness, I'd be having, these discussions with them about what their goals and values are, and to empower them to ask their specialists to actually be involved, to have and I was naturally doing that on my own accord. I, always advise patients and their supportive decision makers to write out their questions on a paper, not to forget, because people forget whenever they go from one specialist to another, and not be afraid to ask questions that are not necessarily raised by their healthcare providers. And if I had access to your worksheets, yeah, and I would, have been so inclined to just, direct them to these worksheets, direct them to the book to say, and I just wonder, would family physicians and GPs actually benefit from being aware about your book and these worksheets, to actually incorporate this into their daily practice discussions. But then it comes to the next question of, does it have to be endorsed by the Royal College of General Practitioners to actually be on the RSCGP's website as a GP toolkit for GPs to use when having navigational discussions with patients. So
Yeah.
you know
Yeah, I mean,
I'm
we've always found that the less barriers to entry is, it's going to spread farther. But when you say these worksheets, you mean from our workbook. Is that what you mean? Because we didn't have, when I met you, we didn't have yet the workbook. And that is a new thing that we just came out with, and like a couple months ago that just came out.
Oh yes,
And
not the workbook. I think, yeah, I've seen, yeah, so I haven't gone through the workbook yet, but I think you sent me a link on individual flow charts, for example, for dementia or cancer. And yes, those
yeah,
flow
so
charts.
okay, thank you. Yeah, so those are we call them illness roadmaps. And
That's it, the
it
roadmap.
really
Sorry,
connects to zoom
apologies for
out the
not using
big
the
picture
correct
of the
term.
illness. And we were
Yeah.
collaborating with disease organizations to create disease specific, I guess, illness roadmaps that talk about the beginning,
Yes.
middle, late, and end stage of Alzheimer's, COPD.
Yes.
We have one on ALS and motor
Yes.
neuron disease. So
Exactly.
those are worksheets that are free available on our website. And
Yes.
from that
Yes.
whole experience, we realized we need sort of worksheets for all of it. And so we created this
Yeah.
workbook that goes with it. And there's QR codes with printouts of those. There's a generic roadmap.
Mm,
And Sammy is, has 20 other diseases. So it's going to take us some time to get through them all. But we are, I think there's a world where we can, they don't really need us to do it, but people can create them on their own. But it is this idea that this information exists and the pattern of every illness is known, and people don't have to be in this limbo. And
yeah.
I do hope that if patients at the end of it is a one-page CV, we call it My Big Picture. It's a one-pager,
Yes.
and it talks about the
Yes.
7 keys on one page, like how you like information, who's your inner crew, what are your goals and priorities, which is what's important to you, and you bring that to your clinician as your one pager summary, and they will know how activated you are and whether, you know, uh, who's important to you. How much do you want to zoom out? And that can help shift the conversation. That's our hope. And we have a whole program around teaching the workbook exercises to the public
Yeah.
and activating doulas, and we have free workshop materials for anyone who wants to. We call them ambassadors, and we are now coming back to the provider piece. But the hardest thing about providers is not what is the knowledge, but it's what's their motivation to learn that knowledge.
Exactly.
And
Exactly.
then
It's the
and
motivation.
how do you actually change their behavior, and can we
Yeah.
measure if their behavior changed, and does it improve patient outcomes, right? I mean, I think
Yeah.
clinicians want evidence that if I do this, it's an improving patient outcomes, and that's the hardest thing. So we do
Yeah.
have research that we're embarking on in that world, but it's harder than you think, because I think where you and I are similar is we're very interested upstream, and a lot of the
Yes.
palliative care research is at end of life because that's easy to measure,
Yes.
and it's
Yeah.
important. But if we do some of the things we're talking about, it doesn't need to be in the last weeks and months. It can
Yeah.
happen at the beginning of a diagnosis,
Oh,
and
for
frankly
sure.
any diagnosis, not just
Yeah.
a serious illness or a progressive life-limiting illness.
Yeah.
So, conversations about who's important to you, advanced care planning, inclusive care, that's true for every patient and family.
Yeah.
Yeah.
I'll give you an example, Sian. When I gave a talk during my radiation oncology term last year at the Calvary Mater Hospital, I did talk about uh, frailty index scoring assessments as a guide to indicate the future risk of hospitalization. And with radiation oncology patients, for frailty to be a marker to prompt as well, to have discussions using the roadmaps on what your goals and values are for future hospitalizations, as to what you would want done, what you would find acceptable and not acceptable to give you meaning to your life at that point in time. And when I showed, your web link of the Waiting Revolution, and I brought up your roadmaps, people were taking pictures of it, nurses, OTs, and physios, and going back and reading up on it. And they're saying, many people walked up to me after my talk saying, "Oh, Ash, if we had these templates to give out to patients in clinic, we definitely would, to actually help empower them to then go back to their medical oncologists, who are separate from the radiation oncologists, as you know, and go back to their GPs, geriatricians, for example, to actually then, make all of the other stakeholders in that person's care aware that this is what this person wants to know at this point in time. This is what's important to this person. So when they do end up deteriorating in the last, months or weeks of life, which is very often when they sadly get referred to palliative care and not earlier on,
Mhm.
I just feel that we'll have a much more meaningful interaction with the patient when palliative care come to the fold, when the patient and their substitute decision makers have a baseline level of understanding about zooming in and zooming out, and where they are at their illness at that point in time, and what their actual core value needs actually are.
Yeah, so I'll have you know we are working on more roadmaps. We have um, translated into French and English.
Oh,
And
wow.
early in 2026, we will work in a global. We have a global ambassador program, so we have like 300 people from around the world. So we will have. We're gonna try and start a translation project where people can translate it, and we already have a printer friendly, like a black and white printer friendly version because we designed it in color, and people were like, it's too colorful. And it's too much ink. So we've a simplified black and white version. So
Yeah.
those roadmaps are very popular. They've been downloaded, thousands of times, but and are free, and are not unique to Canada. But still more work to be done because we haven't covered every illness, of course.
Yeah.
But also, it doesn't. We don't hold anything special. We co-design these with patients and families. But it is the heart of the idea is that the information exists about the big picture of the illness, and people can, if they want, they're knowing what's ahead. Hope and preparedness, hope and planning, hope and uncertainty can coexist, and it can start new conversations if they know these are things I should be thinking about, and I just didn't know I should be thinking about them
Yeah.
because I've
And
never
yes,
walked
yeah,
this road before, but clinicians have. Yeah.
yeah, I just had a thought that just popped in my head as well before I forget, that in these roadmaps, it would be lovely if there was a reference to forming one's own compassionate community at the outset of them receiving that diagnosis. Because, it's the same thing like I spoke about the trust discussion before. They may not make a decision about that then, but if you plant that seed, they will come back to it at the various points, and actually, maybe even make references to the local community network connectors within the geographic area that patient lives in, to actually be aware of the community resources that they actually are.
So in our workbook, we before we even get into the roadmaps, because some people don't want to look that far, we have 5 questions. Help me ask the right questions, and it's 5 questions, and the fifth one is about resources. And the whole chapter, anticipate ripple effects, is exactly mapping out who's in your inner ring, second ring, third ring. We put out know the job description as an exercise where
Yeah,
we talk about different roles and who you might put there. And we also flag like, if the same person's there in every role, like there's risk of burnout, they're your caregiver, we know this is what the system would call a caregiver, et cetera, et cetera. And we talk about plans for respite. So the workbook is actually, I'm going to send you a copy. It's a very, practical extension of
oh,
that. And
please
I
do.
think we mentioned a few times about starting looking for social, the idea that your community and it's not just physical, but the emotional and social connections are really
Yes.
important for various conditions, all conditions really. But thinking about that proactively because that is what brings people, joy and quality of life, and not just, thinking about the disease, this physical symptoms all the time. So, um, but yeah, I'm excited to see if just hear your reactions to that when we get there. We're almost at the end of time. I wanted to end with asking you about what are some of your biggest hopes for the future?
Oh gosh, that's not a big
Are
question
you
at all, is it?
optimistic or are you a pessimist about how the health system is gonna to unfold?
Oh, look, I think it'd be remiss of me to say that I'm not optimistic. I am an eternal optimist in my nature in itself, but having worked on both sides of the world, having one foot in the community and one foot in hospital care, and now being a full-time hospital palliative care doctor, I think I'm optimistic with the fact that people in general in healthcare are aware about the unknowns and the need for more inclusive training, inclusive care, and individualized care, which basically means the same thing, really. I think the time's come for a revolution in general. A reckoning definitely is here because every specialty and department it, within healthcare are basically saying the same thing in a different way. And that's been my observation about what their patients' needs are and the gap holes in providing inclusive care and holistic care. So I think the time's coming. Whether or not we'll get there in an expedited fashion, that still leaves to be seen. But we need people like yourself and Sammy, and we need grassroots organizations like Compassionate Communities Australia working with palliative care and aged care organizations to help to provide that ongoing network, basic network to support future grassroots discussions. I think one thing that I am optimistic about the future is grassroots collaborations. Um, as a palliative care physician myself, I'm hoping to lobby for more grassroots discussions between palliative care and geriatricians, specifically when it comes to geriatric syndrome management, dementia management, and goals of care discussions, and the age-old chestnut of behavioral and psychological symptoms of dementia, which everyone struggles to actually manage. So,
Hmm.
yes, I'm optimistic about the future, but also being pragmatic at the same time that meaningful change takes time, especially within an institution.
Yeah, you're balancing hope and reality, Ashwin. I get it. I get it. Hey, it was a pleasure talking to you. Thank you so much for joining us today.
Thank you, Sian, and I'm looking forward to meeting you in Brisbane.
For sure. Thanks for listening. Our workbook, Applying the 7 Keys for Navigating a Life-Changing Diagnosis, is available now at all online bookstores. Visit our website for more details and to access our free resources, event listings, and learn all about our movement. The best way to keep up with us and our work is to join our newsletter list, or better yet, become an ambassador. This episode was produced by Maggie Sivak, myself, Kayla McMillan, Shilpa Jyothi Kumar, Bethany Bachanfuso, and Kathleen Bartlett. Our theme music is Maypole by Ketsa.